Let me just give you an example of a case, 35 years old male with end-stage renal failure on hemodialysis. He was a transplant, he had a transplant rejection and was on maintenance hemodialysis and was a prospective patient for renal transplant. Again, the second transplant, there was history of pulmonary embolism in the recent past, and the recent workup actually showed there was 6 centimeter thrombus in the right atrium attached to the right atrial wall and to the internal jugular vein. This is the CT angiogram. You can actually see a big thrombus in the right atrium. Again, this is the same CT showing that there is a catheter, and below the catheter there's a huge thrombus in the right atrium, which has very high potential for embolization. Now again, this is the echo, which is showing a right atrial thrombus like a ball, and the size of this is almost twice the size of the main pulmonary artery and RBOT. So you can imagine any intervention at this stage can just make this thrombus fly up and obstruct the RBOT, and it will act like a ball wall and get a patient to immediate cardiac arrest. But the situation here was that the patient refused surgery. The patient was advised surgery and open surgical removal, but he refused surgery, and then we had no other option but to go ahead and treat it. Now, this was one of our first case, and we were pondering what to do. And suddenly, we were looking at options, and a thought came to my mind that every thrombus has an acute component and a chronic component. So what if we go and lyse this clot and put the lytic agent near the clot? We may actually reduce the size. We can take care of the active, a large thrombus and make it a smaller thrombus, and then think about possibilities, how we can take it out with endovascular technique. So with this thought in mind, we actually went ahead and did a lysis through the jugular catheter for almost 24 hours. And what you see now is that the clot actually reduced in size, and this made us more excited to that now we can remove, but we had no other, we had no device to actually remove it. And while we were thinking, a thought again came to my mind that, if we can use the capturing device of an IVC filter to the retrieving device for an IVC filter, probably we can take this clot out. But the issue is the clot is not in one direction. While you are putting in a retrieval device, you will only go in one axis. How to make that coaxial and how to catch it in that direction. So post-lysis, what we thought, let's go and take the help of imaging from echocardiography also, and and then try to get into a bicaval view and try to make it coaxial. So before that, we did a bench test, and this is a bench test, whether we can actually retrieve this clot without fragmenting this clot and causing pulmonary embolism, and actually we were able to do it. And this made us more excited that probably, yes, this is the way we can take it out. So we use this hardware. This is the hardware for retrieval device of IVC filter, and this is only one company makes this, because it has a net and a mesh around it, which is non-porous, so it can catch. It's a cone which can actually catch the thrombus without embolizing or crushing the thrombus. So we went ahead and did the procedure in a bicaval view in the cath lab with the help of echocardiography and also with the help of a fluoroscopy. And once we had this and we were aligned coaxially, we actually went ahead and docked our retrieval catheter onto the clot. You can see the retrieval catheter here. And once we did that, you can see that the device actually opens and retrieves the clot. We captured this in the fluoroscopy also as in echo, and you can actually see we are coaxial, and we can catch the thrombus and then take it out coaxially. And while we got this coaxiality in that view, and also passing in a wire and retrieving it and having a good veno-venal loop. This is the post-operative, immediate post-operative echocardiography, which shows complete removal of the clot. And this is the immediate post-angio, shows the complete removal of the clot. this is the clot which we removed. So the CT confirmed the finding. There's another case of similar variety. I'm going to skip this. And subsequently, we have done many more cases, and I'm going to be skipping this. And then we published this result and this technique, which this was widely accepted. And now this is one of the ways we can go ahead and treat and take out RA clot in difficult situations where surgery is either contraindicated or it is refused by the surgeon. So just to give you half a minute on potentially embolic RA thrombus, there are two varieties. One are catheter related and one are RA thrombus in transit. RA thrombus in transit means that you have an DVT or an IVC thrombus which actually moves to RA and RV and to pulmonary artery. It can, in that transition, it can go and get stuck in the RA for some time, and you have a situation where there is a patient is potentially to have a large or massive pulmonary embolism, and you can do something to take it out. Now, the incidence varies from 2 to 29%, and the mortality in hemodynamic patient is 18% unless we don't treat it, and mortality in non-hemodialysis patient is about 40%. There are different ways to manage it. One is a catheter-based management, which I told you. The smaller ones can be just treated by anticoagulation or thrombolysis, but sometimes we have to opt for surgical thrombectomy or percutaneous thrombectomies. So I'm not going to be discussing this, but this technique was described and published, and now it's accepted as one of the very important techniques for taking out the RA thrombus related to the catheter, especially the RA thrombus which are quite big. So I'll stop my slide here and open this for discussion.